Okay, exam one review, take two. Here we go. And let's get you into all the slides. So here we go. And the first thing I told you that we're going to have to be worried about is the theorist. I told you you're going to hear Erickson, Piaget, Freud, Kohlberg. Those are the four, and you're going to see them. And they're going to be either infant, toddler, a preschool, your adolescent, school age. There's going to be something in each, but you know, the way that I describe in my classes, you'll be able to see it, okay? So here are what we talk about Erickson. Remember, trust versus mistrust. You know, like poor Leslie, that kid trusts you because you're going to go and pick it up. Because if he cries, you're there. Because if you don't pick them up, they don't feel secure, they're not happy, and there is no trust. So trust versus mistrust. Very simple with an infant. Now, toddlers, what does it mean? Autonomy. What are toddlers? Me, mine, I do. Me. Okay? So that's the autonomous, being autonomous. That means acting onto themselves. But there's mommy, there's daddy, there's Nana, there's pop-up saying, be careful, don't do that, don't do this, don't do that. And that becomes their shame and doubt. Because like, should I have done that? Or can I do that? That's that wonderment in there, okay? So it's the parents, whoever, the adult saying, be careful, that stops them from being completely autonomous. Of course, we're protecting them from safety. Now, initiative versus guilt. Now, preschoolers love to do things for you, but they're afraid to make those decisions at this point. They're already concerned about, did I do it right? Did I do the right decisions? Now, school age, you're going to see all over the place. Okay, I'll tell you, school age, you need to understand. Industry, what do I do well? Do I cook well? Do I swim well? Am I good at sports? Am I good at spelling? Am I good at math? Whatever I'm good at, that is my industry. My task, I do well, my industry, and makes me feeling pride and accomplishment because I do that well. But I'm inferior because I can't do everything well. And I want to do everything well. Because remember, these are pleasers. These school age people like to please. And if they can't do it, they're inferior. Now, adolescence is that identity versus confusion. Now, just think of body image. Who am I? What do I want to be? What sex do I like? What am I going to be when I grow up? What group do I want to fit in? Am I a band group? Am I a nerd group? Am I an art group? Where am I in life? So identity, remember, they're going through, they want that feeling of their peers to accept them and like them of who they are, okay? And that confusion is they don't understand where they're going yet, especially when you talk about the younger adolescents. So remember, body image is huge in the adolescents. Too many pimples, too curly hair, too many freckles, could be. So Freud, remember Freud's all about something sexual or relationships, okay? So initially, what do kids do? They suck everything, explore the world through their mouth. Then they start potty training when they're toddlers. And then all of a sudden in the preschoolers, they start seeing that they have these body parts and starts playing with them, part of it. Also, remember, girls like daddies and the boys like mommies. It's just part of what their preference is at that point. Now, the latency part is what we call in Freud about being with same-sex peers. That later part of that school age, not in the really beginning at 6 years old, but as they get a little bit more, that is the one they want to have, you know, their best friend, right? They like their same-sex peers. And then, of course, it goes into adolescence. It's all about genitals, opposite sex, and all the sexual parts that go with it. So Kohlberg, all about moral development. Now, what is morality? Morality is right and wrong, right? And knowing there's a consequence for each. So how does that build as we get older? Well, initially, they start to learn right and wrong, and there's a consequence for right and a consequences for being wrong. And they're starting to realize that. Then all of a sudden, this conventional is what they're starting to want. This is like your school age. They want to do right. They want to please. They're pleasers. at this stage. They're not going to steal something out of a store because their friends did, not because of the punishment, but because they want to please. They don't want somebody to say, I failed somebody, especially your parents, right? Because again, you also know that there's a punishment, but it's mostly that pleasing. Post-conventional is you go to work, you do a job, you have to do what they say. You just conform to what you have to do. And it's understanding that you have to do that, those rights accepted by society. It means you're not going to run around naked in the middle of the street because people don't like that, right? That's part of understanding society and doing the right things, and also conforming to what you have to when you do, because there's, you're going to get gains from that also. It's just another picture of all about the morality and some other things that we discussed, but it's basically what I just said. Now, Piaget is all about the mind, and the mind learning building blocks, starting out with just taking a finger and it finds its mouth and go, "Ooh, I like that," and it was an accident. And then it's grabbing that rattle, and all of a sudden you move and it shakes. And you're like, "Ooh, I like that noise." You see, we're starting to learn by accident, and then we start remembering that and building upon it. Okay, so initially, it is that sense of gratification, that sensorimotor that we talk about. It's also said by Freud too, but Piaget says it about finding things because it's through the mouth first, and then developing that tertiary circular, riding horses, which is a broom, or they're airplanes, knives, and the knights of the round table, and fencing and whatever. These are all, remember, we're trying to imagine, we're figuring out these things. As we get older, it's concrete operational, where concrete means they know things. For instance, they talk about that conservation. And I don't like the word conservation because I think of many different things. But remember that conservation has to do with the little short glass that's fat and round, and then you have the tall skinny glass. If you pour the tall skinny glass into the fat one, there's still the amount of same liquid in there. A school-age child will understand that. A preschooler will think that the tall one had more liquid because it looks more. That's that concrete operational. They're starting to put two and two together. You have 10 coins, no matter what shape you put them in, there's still 10 coins. This is what they're saying. And then formal operations. This is when they really take all the information, all the learning, all the cognitive development, and they start using it. And I'm telling you, they use it towards the parents. And the examples I give is, you tell your son, your daughter, who's, 15, they can't go to something on Saturday because whatever reason, they've been bad or they didn't do this or that. So that week before, this child all of a sudden is making his bed. He's, taking his baths without being told, taking the garbage out, helping with dishes, doing the exam at school and getting a good grade and listening, because they're figuring out, how can I get mommy to say yes now? So they're really, really thinking, okay? Play will always be important. We play even to this day. I still play a little game on my phone because I think it helps my mind keep clear. It's all about, making words. But, as infants, we first do that rattle. As we get older, it's that crawling, it's the blocks, it's putting it in, taking it out, it's clapping, it's playing, it's peekaboo, it's all those things. But we do have names for some play. So onlooker is when you're looking at something and seeing what's going on. Solitary is a kid playing alone, whether they're in a corner or not, they're just playing alone by themselves with their own toys. Parallel play is two children or more playing with blocks. They're still playing the same thing, but they're not playing together. They're doing their own creations their own way. Now, associative is now they're playing together. They're playing with the blocks together, but there's no rhyme or reason. What's the goal of it? There is none. It's just they're playing together and they're creating nothing, right? Now, cooperative play. The kids say, okay, look at these great blocks. Let's go ahead and let's build a house. and a barn and a this or a that. So there is a goal to it. Just like a board game. Checkers, as the kid gets older, they can play it and understand it. That means the goal is winning, getting all the checkers, right? And having the last piece left. So that is when there is a goal, cooperative. Now, cultural differences will always take a part of how we treat our children or our adults all the time. And I want you to know, I came to South Florida over a long time ago, 40 some odd years ago, I think. And I didn't know culture at all. I was in a very small little town. I didn't have cultures from all around the world. So I came down and I had to learn. So how did I learn? Well, I asked the child, I asked the patient, I asked the family, the parents, and I found out a lot of great things. And you know something? They were so glad that I wanted to share because I'm the really, white American girl, right? So I'm asking what they feel, and it really made a difference in the way even they treated me. They would even bring me different food things to share their culture with me, which was great. So always ask. Now, some cultures, there's difference in dietary restriction, different in what caregivers that can go. We know that there's vegetarians, people who don't eat pork, people who don't eat beef. So you ask, why would you want that to show up on your tray if you can't eat it? It would sort of disgust you if you're not used to it, right? What about those cultures that are always covered all over? Now, if there's a woman, they do not want a man going in there and taking care of them. It's against their culture. So we wouldn't do that to them. But how would we know? Well, we ask, what their preferences are. And then, of course, respecting their bodies as we are doing examinations. You don't have to take all the clothes off, all the blankets off. You do it piece by piece by piece, right? So again, a part of it is cultural, which is the spiritual care, giving them that chance to do their practices. We know some religions pray 6 times a day. Now, how would you allow that? Well, it's not that you allow it. You fit your schedule and they fit their schedule around you so that they can have their peace and time to do what they want to do because it makes them feel better. And if mentally they feel better, they're going to physically feel better. Now, assessing a child, you're never going to do a head to toe. So forget about head to toe assessment. This is not an adult. So number one, you need to get down and stop towering over these children. I sometimes will have a child, like my last part of my career was in the ER. So mom would be sitting there on the stretcher with their child. I would bring a chair up and even sit lower. And I would sit there and start, doing some cooing or some tickling or where's your ears or, oh, that's a cute little shoes you have on. Just nice little happy thoughts with a great voice. And even infants do warm up to you. Because, infants are very like stranger danger, right? Especially like after 8 months old. If you have a kid asleep in a parent's arms, oh, that is a perfect time to listen to breath sounds and to heart sounds. Because once they're awake, they're always making noises, they're moving, and it's really difficult to listen to it really well. Now, one of the things that we need to do a history on is, remember, children, if you're a pediatric nurse, your responsibility is to keep that child safe. And sometimes even the caregivers bringing that child in are the ones that are making are getting that child unsafe, and it could be abuse. And I've seen several cases in my career. So number one, when you're doing any sort of history from a parent about an injury, also ask that child if you can get them alone. Sometimes you're doing an x-ray. It's a great time to go with them when they're in the room and get the mother out and just say, so tell me, how hard did you fall when you fell down off the monkey bars? Little something to see, do their stories correlate or are they different? Okay. Now, another turnaround of this is, what if you have a child comes in that's been molested by somebody and the parent brings them in because they want them examined because they're so concerned? Remember, there's a child there who's been abused, but remember those parents' feelings. That parent is just out of her mind upset. that somebody did something to her child and she wasn't there to protect. So remember the parents' feelings. Now, there's a history that we take, and there's a physical that we take, right? So physical is anything you can hear and touch. So vital signs, height, weight, and then listening to their body from head to toe. That would be physical. Now, growth. Well, what happens with growth? Nutrition, nutrition, nutrition. Without nutrition, a child is not going to cognitively and physically and motor, do what they're supposed to do. There was no gasoline in the tank. So how are they going to move and think when they don't have fuel to feed what they're going through? We have children that are born at 7 pounds, and at 1 year old, they are 21 pounds. And the first 6 months, they're growing an inch a month. I mean, this is incredible amount of growth going on. If they're not fed, how are they going to grow properly? How are they going to be able to turn over and lift their heads up and crawl and creep and walk? So very important that we look at these children and measure their height and weight and know, are they gaining weight the way they should? And then look at those developmental levels. Now, sometimes you have an infant with maybe the weight is low or maybe the weight is high. Either or, it doesn't matter. If you're seeing this, what we'll ask is have that parent do a 24-hour diary. We do this on the adolescents too, when they have feeding issues. But with infants, we're going to do it to see, well, maybe they're not feeding enough. Or if it's high, maybe they're adding fruit juice or something that's just empty calories, which is making them with their weight too high. So either or, we're going to figure out what we need to do in order to put them where they need to be in that normal. As I said, adolescents, these children are those also growing a lot in the beginning, that adolescent growth spurt. Now, a lot of them, looking at nutrition, tend to have overweight. So when we're looking at overweight, risk for overweight, when you're in 85 percentile, you are considered a risk, okay? But when you get to 95 percentile, then you are overweight. And again, how do we look at their nutrition, like I just said? Get a food diary, find out what's going on. Now, we sort of started to mention about these frequent assessments, developmental assessments. Why? Sequential. What in sequence aren't they hitting, right? So we can see, are they lifting their head up by 2-3 months? Are they rolling over by 5-6 months? Are they creeping, crawling, walking? And if they're not where they need to be, children are phenomenal. Give them a little bit of early intervention, speech therapy, occupational therapy, physical therapy, and these kids catch up really, really quick. So we want that to happen so that they're not left behind. And again, we're going to look at nutrition with that. Now, when we look at the abdomen and look at anything in a kid, first of all, take a visual. What does it look like? Is it round? Is it soft? Is it concave? Do you see a hernia? I mean, umbilical hernias are very common. So look at that. Then you're going to auscultate all the breath sounds. You're going to percuss to see, is there any fluids, masses in there, or feel that gas, right? And then we're going to palpate. Are there any lesions or cysts or anything in there? And we can actually even palpate. Do we feel the liver? I mean, we should be able to laying down, but sometimes if it's coming down, there's other reasons for that. Now, next semester, many of you are going to go into capstone, and part of your sim that you have to do in order to pass, you're going to be doing some sort of cardiac assessment. So this is how we do one on a child. So knowing where to listen for certain valves can help, and especially if you want to work in a cardiac intensive care unit. And I did work in one for 10 years, and probably my favorite of all my nursing assignments I've ever done. Although the ER was great to prepare me for teaching, because then I saw everything. So know where to find these things. I'm not going to go into it. You can read them: aortic, second intercostal, pulmonic, center intercostal, left sternal border. Just know where they could be so that you know where to place a stethoscope. And now breath sounds. Now, breath sounds in children are really tricky. And the reason is they have a shorter neck and they have all this upper airway mucus, as I call it. You know, I teach those new nurses coming in and even student nurses who come to do, a clinical, and I get to follow them around and teach them things, to listen to their neck. And do you hear that mucus there? You can also do it the tracheal border right by the substernal notch right there. And this is your trachea. And we can see, is it upper or is it lower? Very important, because you might say there's bronchi, but it's just upper airway mucus. Have them blow their nose, right? So this is where we listen to those things and why we do those different sort of breath sounds. It's not just listening to lungs, it's listening to that upper and lower. Now, car seats. As I told my class, I remember that metal car seat. And it was in the front seat, and it was my brother was next to my father driving. I was next to my brother sitting in the front seat with my mother next to me. That's how far car seats have changed. But I'm an old lady, so it's been a long time ago. But the car seat safety, what do? Well, remember, at birth, for the first 2 years of life, it's rear facing in the back seat. Make sure that those harnesses, straps, snugly fit. And make sure at 2 years you can turn them around. And, I had a grandson that was really small. They say 30 pounds. He was only 24 pounds, but he was a peanut the whole way through that first year or two. So make sure that they said that even though he was small, he had the motor capabilities. He was strong enough to turn him front facing. And remember, don't use an old car seat. Don't use one from any sort of, flea market or garage sale. You don't know how old it is and it can expire. And that's a little bit more that you can look at it. So let's go ahead. Let's look at this infant. We know the infant, there's so much stuff that goes on, right? It happens so quickly. So what is a head lag? Well, you pick them up and they're 5, 6 months old and their head falls back. When you pick them up, their head should come with you about 3 months old. So that's a problem and something to look for. They should be sleeping on their back to sleep because, it's that SIDS death and it does prevent it. They should roll from their abdomen to back at 5 months and back to abdomen, at 6 months. They, when they're on their backs, they're going to start finding their feet, right? Their hands, everything in the mouth, They're going to be grasping objects, a voluntary grasp about 3 months. And you're going to start seeing tooth by about 6 months old. But remember, not every kid follows this completely like it says. Some kids will be different, but as long as they're moving forward in their development, they're doing okay. They should pull the standing about 9 months, and children should sit unsupported, nothing, no pillows, no nothing around them, by about 8 months old. Colic is, a really difficult thing for parents to deal with. I mean, that's your colic carry where you try to shake them and get them moving and get the gas out. But it usually lasts up to about 3 or 4 months old, maybe up to 5 months. And it's this kid who's crying. And a lot of times they're unconsolable. And they try all medicines, they try different formulas, this, that, and the other, but we don't know why. It always happens. We think that maybe they were born premature, but there's a lot of full term. It doesn't matter if it's breastfed, bottle fed, it doesn't matter. Now, knowing that and knowing that's normal, you're a nurse at a urgent care or ER or a doctor's office, and a parent calls you and says, my infant, let's say 4 weeks old, is crying more than 8 hours a day. Never assume it's colic. There's a lot of other stuff it could be. Make sure they get in and get some medical help, either to the ER or to their pediatrician's office. So developmental periods, sequential trend. Like I said, lift the head, then you go from your tummy to your back, back to your tummy, then you get on your knees, and then you're going to be crawling and creeping, standing, and then you're going to be walking. This is just part of what a child is expected to do. Remember, they're all different. Developmental pace, it's just when they do it the way they want to, as long as they're moving forward. And there's something called sensitive periods. That means at this period of time that children all of a sudden are doing a lot of big things. They go from not talking and now they're saying mama, dada, and this is important. Or they weren't walking and now they're running. That's your sensitive period. Now, those soft spots, fontanelles, we have them anterior and posterior. Posterior should close about 6 to 8 weeks. The anterior should be open and close, they say about 15 months, but they say 12 to 18 months. Very important that we check that. If they close too early, how's the brain, the head going to grow, right? There needs to be space there. Or what if it's still open at the end of these times? It needs to be investigated. Why? Is it a hydrocephalus? Is it a brain tumor? We don't know. Now, binocularity, it's like, think of the binoculars. There's 2 places to put your eyes on. So this eye looks here and this one looks here. That's how infants see initially. By 4 months, they work together. I mean, if we put our finger out, both eyes will go to it. Infants, initially, they don't. That means there's no depth perception. As they get older, they're starting to get that depth perception. Their eyes are working more together and they can grab it easier. Now, pain. Pain is a thing that we've started, really to investigate and look at. It was always said that children, infants, they don't hurt, et cetera, et cetera. But they do. Children do have pain, whether it's gas, colic, reflux, all these things. So what do you see? Infants, pain scale is flat, right? What do you see with flat? Faces, those legs moving, that activity. Older, kid maybe just laying there, afraid to move, all right? Or crying or consolability. So that little quivering little chin, those hands, those fists clenched, these are things that you're going to see a kid is in pain. So how do we work with pain? Well, we're going to give, do the flack scale. We're going to assessing what their pain is, and we're going to be medicating them. Remember, Tylenol is all we give, acetaminophen for the first 6 months of life for that over the counter. After that, at 6 months, we can give ibuprofen, but the first 6 months, it's acetaminophen. Now, what if a kid's pain is more than that and they're in the hospital? We do give morphine, and morphine is great to use, and it's a very well-tested drug. It's been around since I've been a nurse, and I've been a nurse a really long time. So it has been proven over and over again. Remember, though, there's not giving medicine. Give the medicine and leave. No, what else can we do? We can do distraction, as in put on music, put on the TV, give them, something to look at, a toy that's making bubbles, whatever. Massage. Sometimes their tummies hurt. How about if you lift them up so their tummies are not so stretched? Put them in a chair. And older kids, again, still repositioning, distracting them, maybe giving them an iPad, giving them some coloring, crayons, all of those things help. And then sometimes they need a hot pack or a cold pack. Now, one of the things that, I've taught, my students is sometimes a child will not tell you if they hurt because they're afraid of that, quote, pinch, that injection. So remember, we can use topical anesthetics because we don't want a child to be afraid of getting something for pain when they're in pain, because pain does a lot of, damage to the brain, although remember it's pain, and we don't want that. So we can give different things. So we know that there's intranasal. I mean, they're even given something called fentanyl. very strong, powerful intranasally, and it works great, even on some of the younger kids. IV, of course, you don't feel any pinch, and then orally. And as long as that oral medicine tastes pretty good, they're okay with it. But again, make sure as we're giving pain medicine, we think of those things. Now, I mentioned
I have a
SIDS.
question.
Sure, go ahead.
So what age is the flat pain scale again?
Up to age 3. And at age 3 to 6, it turns into faces. And at age 8, by your book, it becomes numeric. And those are the 3 pain scales you should know. Okay? Okay, SIDS, back to sleep. You know, we've been studying this a really long time. I know back in the 90s, the hospital that I worked at for 20 some odd years, the newborn ICU was watching it and trying to figure out how we could get our children, our infants, to go home and not have these SIDS deaths. So we say that infants that are on their tummies or on their sides will have SIDS death. It's just part of what can happen. And what we do today is just have them on their back. There's that cute little bumper pads, all those things they cannot have. No blankets. Just put one of those big onesie type of nightgowns on them. And they do well with that. They should not be sleeping in the same bed as your parents. You know, they need their own. I've actually seen a larger man in bed with his infant roll over in the middle of the night and smother his child. And they were brought to the emergency room and the child died. So that's one of the other reasons, but again, not to share it. Do not overdress your baby and smoke. Secondhand smoke is huge. That has to do with ear infections and it has to do with SIDS death. Children with no prenatal care, children who've just had some sort of cold, runny nose, it affects the respiratory thing. Maternal age less than 20, those premature low weights, children, and then male infants are more than female. Now, breastfeeding decreases the risk factor to SIDS, but formula fed, there is more risk for it. So infants have reflexes, the way that, whether it's Babinski on the toes, just like you use for adults, but that grasp, you have that reflex and you have the voluntary. And then we have things like the crawl, they get up, they try to rock, and then moral, which is startle reflex. You make a loud noise and their hands come up and their legs spew. It's just part of a noise, or you knock their crib. And then the root, the suck. Take their little chin and touch it, and they want to go there. They want to eat there. So they have all of these type of reflexes. Now, another one they have, which usually comes about 6 to 9 months of age, is when they're falling, they tend to put their hands out. That's what we call a parachute reflex. That means as the kid gets older, if they fall, they're protecting their head, if they can get their hands out there. And that's what this is. Yes, they fall. We all fall. We put our arms out too, right? We can get fractured wrists, but it's better than something going on with the head and concussion, etc. Now, I've mentioned these over and over and over again about the things we do. Now, the one thing I want you to know about this thing is that they roll tummy to back 5 months. Okay, that's our book says. So that 3 to 4 months, don't look at that. It's at 5 months, you know, and then 8 months is when they sit without support, and then they crawl and they walk and they stand, etc. So those are your gross motor skills. Remember, gross is G, get up and go, 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 like Paw Patrol. That's motion. Gross motor is all about motion. Now, nutrition on your infants. First 6 months is only milk, whether it's iron fortified formula or breast milk. Now, they say you should breastfeed till about a year old, and then after a year, you could put them on whole milk and stop their breastfeeding if that's what you want. We know that babies should eat about 8 to 10 minutes on each breast, and you know that they're getting enough milk. you know, I think the most difficult infant to send home is one that's been in a newborn ICU, and we've pumped the breast milk, we put it in bottles, and we've seen exactly how much they're getting. And then they go home and they breastfeed, and mom's like, I don't know, are they getting enough? Well, if they're gaining weight at the doctor's visits and they're 6 to 8 wet diapers, we know that that child is getting plenty of nutrition, okay? Also, you'll see that baby gaining weight about half an ounce a day, which is quite a lot. And breastfed babies should get vitamin D, and it helps with muscle formation, etc. Second 6 months, we're going to start introducing food. We know that it should be entered one at a time, every 4 to 7 days. And don't add anything else new till after you see if there's any allergies. And what is allergies? Well, you might see a rash, you might see abdominal cramping, diarrhea, constipation. Diaper rash is a huge one that I've seen on a lot of them, or like underneath the chin or in the hot folds underneath the arms and the bends of the underarms or the bends of the elbows. You might see rashes, and you might think that could be a rash, an allergy. So something to look at closely. And remember, excuse me? So remember, even though 6 months, the GI system is a little bit more mature, it's not uncommon to see some sort of undigested food in their stool up to about the first year. So you might see some peas or beans or carrots. It's absolutely normal. And again, whole milk, because they need the fat. It needs to be introduced at 12 months if we're going to stop that breastfeeding. Now, first vaccine they get, hepatitis B, usually given at the hospital. Sometimes they don't, and they have to give it at the first doctor's visit, which is in the first about week of life. Now, why is it not given? Well, probably it's an insurance thing. Trust me, I don't like that sort of concept, but it is the reality of insurances, okay? So hepatitis B, they're going to get 3 doses altogether. So something to get. And then we're going to start giving those 2, 4, 6 months. We're going to be getting all of these immunizations. And again, the one thing about immunizations is to remember any shot, any needle you're sticking into a kid, use some sort of topical anesthetic, because that kid's not going to remember going to the doctor and getting a shot, which hurts. Okay, they're just going to remember somebody touched my leg and I didn't feel anything and I got a Band-Aid. As they get older, that's all they'll remember. Now your toddlers, ages 1 to 3. Again, get below them. Don't be above them. They're not going to be responsive to you. Then try to get on their level in a way. I mean, toddlers, you can ask them, where's your ears, where's your nose? And as it says, go peripherally, start with the hands and feet and go forward. And I always firmly believe in parents holding their children. They hold their child, they're going to feel comfortable and they're not going to be afraid, okay? Always, be non-threatening, use a quiet voice. Don't try to rush any sort of assessment. It will not happen. And teens, toddlers, ages 1 to 3 again. What do you see? Well, sometimes toddlers don't tell you, but this kid who is like a blender with a lid off and everywhere, all of a sudden is sitting in the corner and really not moving. They're not playing. They're not eating their favorite foods, and they're not drinking. Something's wrong. So it's something to look at. So again, we're going to be doing that flax scale, like I said earlier. And again, remember, it's just not pain that we're going to give. We're going to do some other non-pharmacological technique, like I've just used right here. Video games, coloring, TV, music, prepositions, hot or cold when needed. Now, these kids, it's like stair-step growing now. It's slower. They gain 4 to 6 pounds a year. And by 2.5 years old, their birth weight will be quadrupled. But remember, they tripled at 1 year. So it took another 1.5 years for them to one more their birth weight. So you can see how they do slow down. One of the things that happens with toddlers, and I know my husband was watching little Christian when he's a toddler and helping my daughter and I out when we needed him. I'd come home from work and he'd say he didn't eat anything today. So I said, so what did he eat? Because what happens with toddlers, they're slow down. Excuse me. And, toddlers, when they're sick, they won't eat. When they don't need to eat, they're not going to eat. They're not like us adults that'll eat all the time, no matter what's going on. They just stop. It's called physiologic anorexia, and it's absolutely normal. So you get a little child in, just like I said to my husband. So what did he eat today? He said, oh, he had half a banana, he had half a stick of cheese, and he had some, say, applesauce. And I'm going to go, well, what was wrong with that? Because remember, it's actually only 1 tablespoon per year of life of food that they do need. Yes, several times a day, but it's not really that much. And again, if they're gaining weight and they're gaining their height, when they're getting visits, they're having plenty of nutrition. It's very hard for parents to figure that out. So the growth in their fine motor development, it's starting to get more refinement of coordination between 2 to 3 years old. We get improved manual, like to the right, to the left. What hand am I going to use? They're going to start throwing the ball at 18 months. And these things are things that we see. I know Christian was throwing the ball with his right hand. He ended up being a lefty, but they, again, using both of them. A toddler by 1-year-old has that mama dada, right? When they enter toddler, all of a sudden they're using multi-words. They want to, me, mine, me do. They want to feed themselves. They want to play. They want to dress themselves, undress themselves. I mean, it may not done properly, but if they're trying, that's a good job. So toilet training, I had one student asking me, what are all the signs of potty training readiness? So you should have to be able to control the rectal and urethral sphincters. And how do we know that? Well, they start to understand, they feel like they have to go number 2, they have to move their bowels, they run, or you have the potty chair there for them, right? Many parents have it in the middle of the living room floor because it's easier. So they sit down and they go. So usually bowel control or bowel is the first thing we can train. Then when you see a child 2 hours dry, that means they are holding their urine, then they're ready for their bladder training, okay? So you should start with bowel training and then go to bladder. Now, injury prevention. Well, we know these kids, is this Jerry Seinfeld thing. I love that saying. Having a 2-year-old is like having a blender without a lid. They're all over, right? Hard to keep up with them. It's that intense period of environmental exploration. They have temper tantrums, no, me, egocentric, mine, give me, mine. And we know timeouts is the best form of discipline for toddlers. Now, preschooler, ages 3 to 6, because at 6 we come into school age. So growth, again, we're still very slow. They're still picky eaters, but they're eating a little bit better than the toddlers. Kohlberg. Now, Kohlberg's all about morality, right? It's all about right and wrong. And as they get older, they're starting to understand as a preschooler those differences now. And we know that toddlers and preschoolers are both, if I do that, mommy's going to yell and I'm going to be on timeout, so I shouldn't do that. Doesn't mean they're not gonna, but they're starting to understand this now, okay? Another thing about morality and understanding rights and wrongs is comforting somebody who doesn't feel well. Like, kiss all better, let me make it better, giving a hug, whatever it is. They're starting to realize other people's emotions. Now, what do we think about with preschoolers? I think I have 6 different types of Band-Aids in my medicine cabinet. I've got Paw Patrol, Spider-Man, Superman, plain ones, clear ones, big ones, little ones, because put a Band-Aid on it and guess what? They're all better. Preschoolers, just like even getting older, they feel that if they are bleeding, if we don't put a Band-Aid on it, all the insides and blood's going to come out. It's just part of what they believe. We're going to be using this Wong Baker's. Let me tell you, these kids are great with it. It's amazing. They'll point exactly what they heard. And the one thing to tell you about children versus your adult patients, children never lie. Children will tell you exactly how they feel, which is great. So they say that it's a number 4, you know that kid is really hurting. They don't say it unless they are. Now, gross motor, get up, go, go, go. That's movement, right? That's in the backyard, that's playing baseball, that's riding their tricycle, playing basketball, all of those things. At age 3, they should be able to walk a line and then like take a board and walk on top of it. They should be able to skip or gallop and walk backwards. That's something they don't do before that. They can pedal a tricycle, they can catch a ball, and they can jump using 2 feet now. Now, at age 4 to 5, it gets a little bit more. They can stand on 1 foot. I remember when Christian started doing that. He was so excited. Standing on tippy toes, hopping on 1 foot, jumping. Oh my God, jump from here to there to everywhere, right? Jumping over things is just part of it. And now they're able to run and stop and change directions, and they're not going to stumble down because they're not as clumsy as they were at a younger age. You know, by age 6, again, we're starting that level of industry. You're right at that cusp of child of being school age, right? 6 years old, they can ride a bike very well. They should be able to jump a rope, and they should be playing, you know, hopscotch. I mean, Christian has, I can't tell you how big this box of chalk I got. It's 100 pieces of colors, so they can use it throughout the next, 2 years. But, doing that little hopscotch and putting the numbers and having them and showing him. Remember, anything you do of play with children like this, make sure, remember industry, something that they can do well. The one thing we do not want to do is give them something that they cannot achieve, okay? So maybe it will be difficult to achieve, but you don't want it to be beyond them, okay? Because they want that feeling of feeling good, that sense of industry. Fine motors, fingers, right? What do I do with my fingers? I can take and thread blocks. I can play with blocks and toys. I can color in the lines. I can button my buttons now. And preschool, this is that beginning, getting ready for school. And it's, understanding that school now is going to be a place where they have to sit, listen to somebody else, and there's tasks that they have to do, right? And they have to be able to be social, and they have to be able to express their needs. So what do we as nurses teach our parents about getting ready? Well, during the preschool age, you should always promote learning is good. Learning shapes and colors and alphabets are all important. And, your numbers. Reading to the children. I mean, many parents do it before they go to bed at night. That's fine, as long as it's done. And then any sort of social growth things like putting them in soccer or gymnastics or whatever they may want to do. So anything that can promote that gross and fine motor skills should be done, letting them play and do things. And these children, we should be speaking to them in full sentences, not baby talk, because what they hear, they imitate. Now, communicable diseases, we think about communicable diseases and we think about the kid and, what they're going to look like. Well, what about you as a nurse taking care of them? Now, many of you do know that I have an autoimmune disease, rheumatoid arthritis. I take infusions. I'm extremely immunosuppressed. I worked in a pediatric emergency room. I never got sick from a kid. And why? When I saw things, I protected myself. I used gloves, I washed my hands, and I put on masks as needed. Now, chickenpox, we think that you don't get it. And we think because there's a vaccination for it, you're not going to see it. Well, I'm going to tell you, even with a varicella or chickenpox vaccine, you still can get the disease, okay? And what would you see? You're going to see this little rash, and they're open and they're juicy on top at all stages of healing. So that stuff that's coming out goes into the environment, into the air, and it spreads. So how do we protect us? It's that N95 mask to keep us safe. Also, because there's other kids that can get it, put them in a negative pressure room. And that negative pressure room gets the air from in that room to outside. It doesn't come back in. All this other stuff is more of keeping your hands, washing your hands, and it's also gloves, and using contact type of precautions, like with diarrhea. I mean, how bad is a diarrhea? Is it everywhere? Do I need to put a gown on? All of those things, you think of that. Now, child maltreatment and neglect. As I said, our job, if we are going to be working with children, is to keep our kids safe. And we need to make sure that children come in for something, that we making sure that the stories match, right? Very important. Now, neglect could be a little bit of anything. It could be a lack of food, shelter, appropriate supervision, medical care, dental care, not getting what they need, treatment is all parts of neglect. I saw a really bad neglect on a father who locked his kid and strapped him to a bed. Believe it or not, this happened. This is true. And didn't feed him. And he came in and he was a skeleton with skin over it. As he got to the ER, he literally took one of his last breaths. He was brought into the trauma room, and I was in another area, and it was early on a Saturday morning. So they yelled for me to get in there to help because they needed all hands on deck. And we saved this child. And it was the mother and the stepmother, and even the grandparents knew what was going on. So this kid, because of his condition, and it was investigated, of course, we called all the authorities, etc. But the kid's name's changed and he's somewhere else, and that family can never get a hold of him again. So the kid is safe. We saw that kid 1 month later, and that kid was alert, he was oriented. I went to pull out a sticker out of my pocket for him, and a $20 bill came, and he goes, "Ooh, $20, can I have it?" I said, "Oh, that's my lunch money." And he said, "Oh, it's okay." So I gave him a couple stickers. But you see, neglect, how an outcome that started horribly. It was horrible. And then you can make that child's life better in the end. We know there's sexual abuse that we need to investigate. And then again, any of that abuse, make sure if the stories don't match, something's going on. And, let your physician know, I'm not understanding this. Remember, as nurses, we spend more time with those patients, those children, than the physician does. So nutrition, preschool, they need 1,200 to 1,400 calories a day. They need good protein because remember, they're still growing. Their muscles are getting stronger. They need good calcium for strong bones and teeth. And understanding what they're eating on a daily basis can say, are they getting enough of what they need? Now, remember, there are some conditions, for instance, like iron deficient anemia. There's ways that instead of medicines, we can just feed them the proper nutrition. I mean, how do we get more iron into a child? Well, green leafy vegetables. Remember spinach, like Popeye? Yeah. And then eggs and also meat can help with those type of underlying. And now school age. School age, ages 6 to 12. It starts with the baby teeth, deciduous teeth, they start falling out. And in the end, It's puberty and then their final permanent teeth. Has nothing to do with wisdom teeth. Those are later. These are the permanent teeth, okay? Again, their growth is stair-stepped. It's little bit by little bit, but this is 6 years of their life. So they will be gaining 1 to 2 feet of their height, and they will be almost doubling their weight. So it's quite amazing how much growth in those 6 years, but it's 6 years of their life. Again, I talked about cognitive and I talked about Piaget and that awareness of conservation. Again, the liquid looks more in one glass than the other, but when we pour it, we know they're the same. And Kohlberg talks about children love to please others. They like to do the right thing. Now, we always worry about injury prevention and protection, safety. So again, any kid, any age, the biggest severe injury is all about motor vehicle, whether they're in the car or ran over by the car, because I've seen that many a times. So one of the things that can cause injuries in childhood is if they're in a stressful home environment. If things are going on in their house that causes them stress, these children will take more risky behaviors. Therefore, there is an increase in injuries because of that stressful home environment. In school age is a great age to teach them a lot about everything. I live in South Florida. I have a pool in my backyard. There's a beach a mile away. I need to prepare my children on water safety, how to keep safe and to prevent drownings. I have seen a pediatrician's son drown. It's a sad thing that happens. Yes, there's all these fences, this, that, and the other thing, but things happen and kids will get in. My little Christian, he by age 2.5 was doing front flips in the pool. He didn't have swimmies on after 2 years old, and he knew how to get to the side and he knew how to get safe and go on his back. This is water safety. This is what they need to be taught. Rear seat until 13 years old. My kids 9 and 11 were in the front seat called shotgun because I was a single parent at that age with them. But it should be kept in the rear seat till 13 years old and in a booster till they're 8 years old. Remember any safety equipment, bike helmets, knee pads, elbow pads, wrist pads, whatever, keep them safe. And ATVs, again, very prevalent down here by the Everglades. There's all this open country, this open country out there. No children younger than 16 should be on the ATV. It's not recommended because they don't have the know-how to keep safe. School-age children and the age of obesity. Well, it is up to epidemic proportion now. 85% is considered overweight, 95% is obese, right? So you're sort of getting there, and then you definitely are. So we should be teaching good nutrition from even during pregnancy, right? And then, of course, as a child is born, all very important. But what happens in these children and why are they gaining weight? Why are they obese? Well, many kids tend to be very sedentary, which means they're watching TV, playing games, or they have their phone that they're, YouTubing like my Christian does sometimes. We need to keep them up and out and moving. Once they become obese at school age, there is an increase in those cardiometabolic changes. And there could be hypertension, hypercholesterolemia, and diabetes could be prevalent as they get older. So something that we need to teach them. There are no cultural barriers here. It's just something that we need to teach children at an early age to eat properly. School-age children, this is that same, school-age children, same peer acceptance. Remember, this is talking all about Freud. Again, sexuality, right now, you need that same sex, and you're going to try to please that same sex person. Taking and preparing them for procedures. Well, you're not just going to say you're going to do an X-ray and this big machine comes over and there's click, click, and this thing is like 6 feet by 6 feet and bang, bang, bang. That kid's going to run out. So again, just say, it's a big camera. It's not going to fall on you. I'm going to move it around, but I would take a picture. And as I told my class, I always will let those children see that X-ray. They want to see that broken bone, or they want to see that pneumonia, or whatever it is, so they understand it. And when they understand, they do a lot better. So ADHD, attention deficit hyperactivity disorder. The major sign of this is distractibility, which means I'm going from this, get distracted, go over to this, get distracted, go over to this, and I finish nothing. I am just running around doing everything but nothing, okay? Many of these children are very disruptive to their classrooms. So they're going to send these kids to the school nurse. Now, the school nurse sometimes would think, well, this is just a spoiled kid doing what he's not listening. That could be done. And it has been in many cases. But what should we do? Well, get the parents in, give them a moment to tell you what they've tried to do with their child. They might have tried everything and they're at their wit's end and they're, please help me. So once we find out the parents, what they've done together, then make a plan, which will be better for the child. Kid with depression, yeah, kids school age and your adolescents, both can have depression. And you see many different things. You'll see sad, hopeless, irritable. They don't like themselves. They don't like their hair. They don't like their nose. You'll hear all of these things. They don't want to go out of the house. They don't want to have fun. You know, they're going to eat more or less, lose weight, gain weight. Both of those things can happen. And they're going to be in their rooms, probably sleeping a lot more than they normally do. A lot of these kids might express, I'd be better off dead. If you get a kid who says that, take it seriously, because these children will commit suicide. So whether they're school age, adolescents, know that. Lymph node tissue, just basically all this says why you get them. Just remember that lymph nodes, like those big glands in your neck, your armpits, your groins, you should not feel them unless that kid is sick. There's some sort of bacteria, infectious processes going on. So if you can't feel it, you're good. Dental health, making sure they brush before bedtime so they get all that sugar off and we keep those teeth as well as they can. Now, they do say flossing is important. Just remember, when you are younger, ages 6 and 7 and younger, you don't have that manual dexterity to do all that flossing. So either the parent can do it or just brushing their teeth is good enough. Using soft nylon bristles and fluoridated toothpaste are good. If you see a kid who's losing teeth that shouldn't be losing yet, it's probably they're not getting the best dental care, and pain is a sign of cavities. And now the adolescents. These rebellious adolescents can be difficult. You know, as a single parent raising adolescents, oh yes, it can be. You have to set limits and set structures and boundaries for them. Remember, they're fighting for independence and control of their environment. They think they're adult enough, they're grown up enough, they should be able to do what they want to do. And all parents are doing is trying to keep them safe. Remember, identity, body image is huge, okay? Because negative body image can cause depression, and depression can cause suicide. Leading cause of death, when we talk about adolescents, well, are unintentional injuries. We know that was car crash, all ages, right? But suicide, and then they're braver now. They're picking up guns. They think they're cool now, or their buddies have them, or maybe it's gang. Who knows what's going on there? But there are an increased incidence of homicide. Nutrition. Remember that adolescent growth spurt. This is 2 to 3 years, and 25% of their height is growing there. So what happens with adolescents? They're busy. They grab a snack bar, a bottle of water, and they run out of the house. And usually they don't eat what they should. Or they're just fast food, fast food, fast food, and eating too much. So it could be either end of the spectrum. So how do we look at nutrition if we're seeing it causing a problem with them? We're going to ask them again, just like we did even the infant, the toddler, 24-hour diary of all foods, so that we know, are they getting enough? Vaccines for sexually transmitted diseases, and what do we do for those adolescents? Well, there's actually two that we want to make sure. Well, the HPV for sure. And again, it is these vaccines, it's in a series, but hepatitis B wasn't always given at birth. So we want to make sure if it wasn't given at birth that we do that 3-dose series, and it can be given to girls and it can be given to boys. So HPV, which is hepatitis, or HPV that we're going to be given to prevent cervical cancers. Talking to adolescents as about sex or anything else. I mean, just a nurse trying to get through to an adolescent, many of them are not going to talk. So you need to, again, somehow warm up to them, right? So again, ask them, oh, that music, what were you listening to? Oh, I like your sneakers. Or, you know, I see that your mom said you play baseball. What position you play? Whatever, start conversation, social thing about what's going on. You know, first of all, you talk with the parent, with the child, and then you have the parent leave. Again, remember, you do not have to tell the parent what they said unless it's something that will hurt themselves or for others. And always let that adolescent express their feelings and always be prepared. They're going to say something crazy. Again, it's that confidence. Again, as I said, letting them know that you're confidential, and that's going to help with your rapport with them. Now, sleep. Adolescents should be getting sleep because they are going through that big growth spurt in the beginning, right? But we know adolescents, what are they doing? They are on the phone, texting, on the computer, or they're at a social activity, baseball games, you know, out at the mall, at the movies, you know, or studying for exams, doing whatever for school, and they don't sleep the way they should. So this is something that we should try to encourage, but we know it doesn't happen. But we need to let them know that getting enough sleep is really important. Depression, suicide, I've said this a couple different times. Just remember, in adolescence, it has to do with intense sociability and an intense loneliness. Let me give you an example. Your best friend, you told her you like this guy. Say, oh, you know, I think he's really cool. I'm going to ask him to go to the movies on Saturday, whatever. And this is a girl talking to her friend, a girl. She walks around the corner at school and there is her best friend kissing this guy. Now, what happens? She's lost the best friend and she's lost the guy that she wants to be with. That's intense loneliness. That's when you're like, I'm not good enough. What's wrong with me? Self-image goes down the tubes, you know, and it really affects them. And it can cause depression and it could cause suicide. We also know suicide can be caused by things that are happening, that whether it's family violence, physical, sexual, or verbal, or emotional abuse can cause a child to have, you know, suicide idealizations. And then Tanner. No, Tanner, you're going to see this on HESEs, on NCLEXs. It's understanding the stages of maturity and as they go through puberty. So menstruation starts 2 years after the changes. So what do we see first in a girl? Breast buds, right? What do we see in a boy? An enlarged scrotum testicles, right? That's part of what they do. In that very beginning, with all this growth and stuff that's going on with girls, it is very common to have irregular menstrual cycles. You know, most parents will say, you know, mark the calendar off when you start to have them to see if there's any rhyme or reason in them. It's because they're gaining height, they're gaining weight, And then remember, when you get your menses, remember women can be very moody, right? They're hormonal is what their boyfriends and husbands, as you get older, they'll say, oh, she has her period. She's hormonal. Give her the chocolate she needs, right? So dosage calculation problems. You'll have 2 DHQ questions, dose over what you have on hand times whatever quantity it comes in. You're going to have mic per kilogram calculations. You're going to have either heparin or insulin drip flow rates. And again, remember, that's a DHQ question. What's the dose that I want over how much medicine was in that bag of fluid, and then times how big that fluid bag was. I did put my recording back down here for you again, and I put the 3 cahoots so you could go back and review them. So, I wish you all the best. I wish you good luck. So go ahead and do very well on your exam number 1. Any questions? Did I cover it for you, Marie? Okay.